CRNA guy here. Just wanted to talk to you about bolusing a labor epidural. So a patient has had an epidural already. Maybe they got the epidural earlier in labor and they were just fine earlier. They were nice and comfortable. And now they're getting up into around 6, 7, 8, 9 centimeters, and they're starting to get uncomfortable again. And the question is, what do you give? How do you bolus an epidural to give pain relief to somebody who's starting to enter, really what's happening is they're starting to enter the second stage of labor as they progress further. And different institutions are different, but at our institution, both our bolus that we give at the beginning and our bag that runs when we start an epidural is comprised of Marcaine and fentanyl. The Marcaine or bupivacaine is 0.1% bupivacaine, and the fentanyl is 1.85 mics of fentanyl per cc. 15 ml bolus, that you can give however much or how little that you think, and then the bag we run at 15 mLs per hour. Now the thing is, the patient has a PCA button. It's part of the teaching that I do after I do an epidural, that the patient will have a button that they can push themselves to deliver extra medicine if they start to get uncomfortable again. And I always tell them, you can push that button 10 times in a row. It's not going to overdose you. You can use it if you need to, but we just ask that if you need to use it, you let your nurse know so that she can check you, because many times when people start to feel that pressure again, when they start to get discomfort again, it's because the baby has moved down significantly and starts pushing on things down below, like perineum, vaginal floor, that kind of stuff. So what happens is, they've been pushing the button a few times. Usually that's the phone call you get. The nurse will say, hey, room 5, she has an epidural. She's been pushing her button. She's starting to get more and more uncomfortable. Could you come and give her something? And so at that point, it's not going to help for me to give any more bolus of that same concentration of local anesthetic and that same amount of fentanyl. Because the problem is, as you enter the second stage of labor, you go from the pain signals that you're getting during the first stage of labor are the uterine contractions, the cervix dilating, and then sometimes you get some referred pain from those things. But the second stage of labor is a different segment of spinal nerves. Instead of your lumbar nerves, and I think like you get up into like the L1 and some of the T1098 nerves for the first stage of labor. In the second stage of labor, it's essentially the pudendal nerve. It's still those other ones a little bit, but you get this sudden increase in pain where just because the baby is entering the pelvic inlet and starting to push on things, it's starting to push on the pudendal nerve, really, again, is the main culprit here. Well, the pudendal nerve is made up of sacral spinal nerves. If I remember correctly, it's like S1, 2, 3, like your 1, 2, 3 sacral nerves. And again, those sacral nerves are not going to get any help from 0.1% of Marcaine and 1.85 mics per cc of fentanyl. That's why they've been pushing the button and it's not working anymore. So what I like to give is it's all kind of like the same medications, but like one of 3 combinations of these 2 medications. Still going to use Marcaine. In some places use ropivacaine. It just depends on the facility you're working in or potentially other concentrations of these things. But I'm just talking about what we do at our facility and what I like to do with what I have available to me. So 0.25% Marcaine 0.25% bupivacaine. So you go from 0.1% to 0.25%. And then the other thing is we're going to increase the amount of narcotic. So instead of this 1.85 mics per ml, which, if you do the math on your whole 15 ml syringe that we bolus with, that ends up being like 27 something mics of fentanyl or something like that if you give the whole syringe. So now I'm going to drop 10 cc's of 0.25% marcaine, and I'm going to add to it 100 mics of fentanyl. So 100 mics versus 1.85 mics per cc, or again, in a whole 15 ml syringe, it might be, like 27 mics of fentanyl. Because again, those sacral nerves, they need a higher concentration of local anesthetic, and they need a higher amount of narcotic to get the same effect, to actually get some pain relief. Now, do you have to give those together? No, absolutely not. You can give the local anesthetic by itself. You could give the fentanyl by itself. Or if you really they're super uncomfortable, you need like the heavy hitter, you give them both together. Just draw them both up together in a 20 cc syringe and do it that way. Now, the times that I'll switch that up a little bit, if they call me and the patient is like 9 centimeters, 8, maybe not even 8, but if they're a multip and they're 8, if they've had 3 kids already and they're 8 centimeters, maybe I would use this way of thinking. The point is, if they're close to maybe being ready to push, if they're almost there, I might just give the fentanyl first, the 100 mics of fentanyl, because that's going to actually give really good pain relief, and it's not really going to inhibit their motor nerves. It's not going to really inhibit their ability to push. So it can be a nice way to give them some pain relief, but not, have the OB, kind of upset with you that you gave something right before they were ready to start pushing. Giving that big dose of local anesthetic that late, you may increase the risk of a forceps delivery, or, them having trouble getting the baby out. So if it's close, I tend to just give the narcotic. If it's a little further away, you could just start with the 0.25% marcaine and give that, and then see if that gets them the relief that they need. And if you need to, you can always come back and give the fentanyl. You could put your 100 mics, you could dilute it in a couple cc's of preservative-free normal saline, make it like a 5 cc total, and just push that later. Or again, and essentially that's what I would do if I was pushing the fentanyl by itself. I would dilute it in a little bit of saline just for the sake of the volume, just to increase the spread. But like I said, or if they're in enough pain and it's early enough, I might just give them both and just a nice double whammy and knock out that pain. Now, all of this, everything I'm saying is predicated on the idea that there isn't a problem with the epidural. It's simply that, the baby has moved down and we're working with different spinal nerves now. If the epidural is one-sided, if the epidural, if they call and they say, this epidural never really worked well, obviously this may not do any good. You may actually either need to pull the catheter back, or you may need to pull the whole thing out completely, because it may not be a good epidural. But again, this is all predicated on the idea that you have a good epidural here. It's just a matter of, and that will be one of the questions I ask. When they call me about a bolus, I'll say, well, did she, especially if I didn't put the epidural in, because usually I know if I put the epidural in, I'm there to see them get comfortable. But, if they say, yeah, she never really got a lot of relief right in the first place, I'm going to be more inclined to start, questioning my epidural, and I'll be a little more worried about whether it's actually a good epidural or not. So real quick, just recap, if you're bolusing an epidural, 0.25% marcaine with 100 mics of fentanyl, any combination of the two. So hey, like, subscribe. If you think of any topics you want me to go over, anything you want me to make a video about, post it in the comments below, and I'll be trying to make a video almost every day, I hope, here, and cover some of the different topics that I normally go through with my anesthesia students. So thanks.